Rheum pathology, gout versus pseudo-gout, or calcium pyrophosphate deposition disease. So let's start out with gout. So what is gout? Gout is just an acute inflammatory monoarthritis. So what does that mean? That means it only affects one joint, okay? But it's an inflammatory response that affects one joint. And it's caused by, what they want you to know is that it's caused by precipitation of monosodium urate crystals in the joint. Okay, so that's very, very high yield. You have to know monosodium urate crystals. They can also call it sodium monourate. Okay, they could just mix up the words. It's the same thing. Monosodium urate crystal deposition or sodium monourate crystal deposition. Okay, that is what causes gout. Okay, now the risk factors associated with the highest risk factor associated with it is hyperuricemia, obviously, because it's urate crystals that deposit in the joints. So if you have more uric acid in the system, in your body, it leads to an increased risk of developing gout. Okay, so the number one strongest risk factor is hyperuricemia. Okay, the other risk factors are male sex, and honestly, the only other one that I care more about is alcohol usage. Okay, so male sex, alcohol usage, red meat intake, increasing red meat intake, that's a big one, and then hyperuricemia, okay? So what causes hyperuricemia? Well, there's two types. You have under excretion of uric acid, which makes up like the majority of patients by far. 90% of patients have under excretion of uric acid that have gout. And then 10% due to overproduction of uric acid, which is less common. Okay, so let's talk about under excretion of uric acid. It's usually idiopathic. We're not really sure why that occurs, but it has some potential association with renal failure. It can be due to excessive alcohol usage, intake of red meat. Certain medications like thiazide diuretics cause hypergluck, right? And the U in hypergluck is hyperuricemia. So be careful about patients that are taking thiazide diuretics. For overproduction of uric acid, what they want you to know is Lesch-Nyhan syndrome. Lesch-Nyhan syndrome is a patient, like a child, okay, is going to present with gout at a young age, okay? And it's just an X-linked absence of HGPRT. Okay, so they don't have HGPRT. So that's what causes the increased risk of gout and hyperuricemia in these patients. Now, how can you tell that it's Lesch-Nyhan that they're trying to tell you about? This is the four things I look for. 1, self-mutilation. 2, male child. 3, motor symptoms. And 4, gout. That's how a patient with Lesch-Nyhan syndrome is going to present. Okay, and the reason behind that is because they have an X-linked absence of HGPRT. They want you to know that. Now, when I say self-mutilation, you're probably asking, what would that look like, Nate, in a question stem for me to find out Lesch-Nyhan? They will usually be self-mutilating around like their fingers, okay? So like they will be like biting continuously at their fingers and at their nail beds, okay? And you could see like them biting their lips and stuff like that. That's how the patient's usually going to present as self-mutilation, okay? Now, what they want you to know on kind of when they put the fluid under polarized light, you're going to see crystals that are needle-shaped, okay, and negatively bifurengent under polarized light. So what does that mean? That means they're going to show yellow under polarized parallel light, okay? So crystals are needle-shaped and negatively bifurengent under polarized light, and they're going to present as yellow under parallel light and blue under perpendicular light. So what I would want you to remember is that the crystals are needle-shaped, they're negatively bifurengent under polarized light, and they're yellow under parallel light, okay? So moving on, what's the symptoms? What's the presentation going to look like for a patient? The patient's usually going to have, right, only one joint that's involved. It's going to be asymmetric joint distribution. Usually the joint is going to be swollen, red, and painful, okay? And it's usually going to involve the metatarsal pharyngeal joint, the MTP joint of the big toe, okay? And that was a question that I missed, I think, on one of the CBSEs or something. And I was so pissed because I knew it affected the big toe. And they showed me a photo of like a diagram of foot bones, and it pointed at different joints on the foot bone, and it said, which joint does it affect the most? Obviously, it was the big toe, but I didn't remember which one, and it's the metatarsal pharyngeal. Okay, so look up what that looks like on a diagram, where that is, and that like anatomically. Also, I didn't bring this up in osteoarthritis or rheumatoid arthritis. They could show you a diagram of hand bones, and then they'll point at different joints on the hand, and they'll ask which one's most likely going to be affected in osteoarthritis versus rheumatoid arthritis, okay? So they do those tricks to try to get you, right? You might remember that the MTP is highly associated with gout, but you might not know what it looks like from a diagram perspective or anatomic perspective. So make sure you know that, okay? So it's usually going to be a painful, swollen, red MTP joint of the big toe. Now, you can also see like potentially tophus formation, which is just like abnormal, like, I don't know how to explain it. More so like abnormal growths on usually like the external ear, okay, or the Achilles tendon, and that's associated with gout as well. It's relatively lower yield, but they want you to know that, okay? Now, some things that can cause an acute attack are going to be large meals with foods rich in purines, as we discussed, red meat. So after they have red meat, they can have an acute attack. Or a patient that has severe alcohol consumption, right? Quick alcohol consumption. The next day they can have an acute severe attack. And alcohol, it's going to be more beer than spirits, okay? That's going to affect the gout. But remember, the reason that beer and red meat affect that cause gout and acute episodes of gout is because these are things that have high levels of purines. And when they have high levels of purines, they get broken down into urate crystals or uric acid, okay? So keep that in the back of your mind. Now, last thing, all right, and this is what they want you kind of to take away, and this is the treatment. When you have an acute episode of gout, the number one treatment is going to be NSAIDs, number two treatment is glucocorticoids, and number three treatment is colchicine, and this is for acute episodes of gout. For chronic episodes, for preventative, you want to give them xanthine oxidase inhibitors like allopurinol and febuxostat. And now gout drugs are very high yield. I recommend you watch the sketchy video on gout like a couple times because it can be a little bit difficult to get the first time, but you should watch it a couple times just so you know it fully. Okay. So there are a couple other things that I didn't really mention that I remember getting questions on that were not specifically in this book. Okay, first off, we talked about Lesch-Nyhan syndrome causing overproduction of uric acid, right? Because you have no HGPRT. But another thing that can cause overproduction of uric acid, which is in the book, is PRPP excess. And what that is, it just means that it leads to the increased production and degradation of purines. And remember, whenever we have increased production or degradation of purines, it leads to the formation of gout because it leads to increased levels of uric acid. Okay, so PRPP excess just means that you have increased production and degradation of purines leading to gout. Another cause of overproduction of uric acid could be increase in cell turnover. So patients that have tumor lysis syndrome, they have increased amount of cell turnover, which leads to increase in degradation of purines, which leads to gout. Okay. Now, another thing that's not on here is that gout is associated with the myeloproliferative disorders. Okay, so keep that in the back of your mind. The reason gout is associated with myeloproliferative disorders is what we just discussed, is that when you have myeloproliferative disorders, you have an increase in cell turnover, and that leads to overproduction of uric acid, and that's why it's associated with gout. Lastly, the last thing associated with gout is going to be cyclosporins. Cyclosporin is a drug class, which we'll discuss later on, and it's used in majority of patients that kind of use it are going to be your transplant patients. But cyclosporins are going to lead to decrease in urinary uric acid secretion. So that causes hyperuricemia as well and has association with gout. Okay, so now that we've covered pretty much everything, I want to run through gout one more time. It's acute inflammatory monoarthritis. The monoarthritis usually affects the metatarsopharyngeal joint of the big toe, the MTP joint of the big toe. The presentation is going to be a joint that is swollen, red, and painful. It's usually precipitated by monosodium urate crystal buildup in the joints, also known as sodium monourate. The number one risk factor is hyperuricemia. It also could be, other risk factors are male sex and alcohol usage. Hyperuricemia can be caused by two things: under excretion of uric acid and overproduction of uric acid. Under excretion is much, much more common. It could be due to renal failure. It could be due to, which is exacerbated by alcohol intake and certain medications, specifically like thiazide diuretics. Okay. Overproduction could be caused by Lesch-Nyhan syndrome, which is X-linked absence of HGPRT, which will present with self-mutilation, male child, motor symptoms, and gout. PRPP excess can cause overproduction of uric acid by increasing production and degradation of purines, which leads to an hyperuricemic state and then potentially gout. Increase in cell turnover, like tumor lysis syndrome, can lead to overproduction of uric acid and gout. Cyclosporins decrease urinary uric acid secretion, so that's under excretion of uric acid. That would be cyclosporins. Now, crystals are going to be needle-shaped, and they're going to be negatively bipharyngent under polarized light, showing a yellow color under parallel light. This is very high yield. You have to know that. Okay? Lastly, it's going to be associated with large meals with foods that are rich in purines, like red meat, okay, or alcohol usage, like beers. What you need to treat them with is acutely NSAIDs, number 1, glucocorticoids, number 2, and colchicine, number 3. Chronically, it's going to be preventative by giving them xanthine oxidase inhibitors like allopurinol and febuxostat. Okay, so that's our overview of gout, all right? Now, what I want you to know also about gout is synovial white blood cell count. It could be from 2,000 to 50,000. Okay, so this can be helpful. So remember, now we have three in our bag of synovial white blood cell counts. We have three things. We have osteoarthritis, which is 200 to 2,000. We have rheumatoid and gout, which are both 2,000 to 50,000, but thankfully they have much different presentations, rheumatoid versus gout. So you could kind of tell the difference between them. You don't have to use synovial white blood cell count just to kind of differentiate those two. Okay, so those are our three things so far that we have. There's gonna be a last one later on. Now, we talked about gout. We have to talk about calcium pyrophosphate deposition disease, which is known as pseudo-gout. Okay? And all this is deposition of calcium pyrophosphate crystals within the joint space. So not monosodium urate crystal deposition, it's going to be calcium pyrophosphate crystal deposition. That is key to differentiating gout versus pseudo-gout. Okay? It's going to occur in patients greater than 50 years old. Okay? Both sexes are affected equally. Not very high yield for you to know kind of those risk factors, but keep in the back of your mind. And what you're going to see on presentation is pain and swelling with acute inflammation. So it looks like gout. The patient will present very similar to gout, hence the name pseudo-gout, okay? And you could also have potential chronic degradation or degeneration, like pseudo-osteoarthritis, okay? But pseudo-gout mainly affects the knee joint, okay? So although gout can affect, it can affect the knee, but the most common place is going to be the MTP joint of the big toe. Calcium pyrophosphate or pseudo-gout mainly is going to affect the knee. So that's one key player there, okay? You're going to see chondrocalcinosis or cartilage calcification on x-ray, which is just calcification of the meniscal cartilage. And the crystals are going to be rhomboid, not needle-shaped, but rhomboid-shaped, and they're positively bifringent under polarized light. So that means they're going to be blue in parallel light, okay? Treatment is the same, NSAIDs, glucocorticoids, and colchicine. And prophylaxis, you're going to give these patients colchicine. Okay. So the main takeaway of pseudo-gout or calcium pyrophosphate deposition disease. 1, they're rhomboid shape and weakly positive bifringents under polarized light. So they are blue when parallel. Okay. Next, the patient is usually going to be affected with the knee joint, and it's going to have very similar presentation of joint swelling, redness, and pain. Okay. Lastly, you have to know chondrocalcinosis, cartilage calcification occurs, and you'll see it on x-ray. And it's known as calcification of the meniscal cartilage is what they'll say. And then finally, it's deposition of calcium pyrophosphate crystals. Okay. So let's compare this all pseudo-gout to gout. So pseudo-gout is going to have calcium pyrophosphate crystal deposition rather than monosodium urate crystal deposition. It's mainly going to affect the knee rather than the MTP joint in gout of the big toe. You're going to see chondrocalcinosis, which is just cartilage calcification, right, of the meniscal cartilage. And you're going to have rhomboid type crystals compared to needle type crystals in gout that are weakly positively bifringent compared to gout, which are negatively bifringent under polarized light. So pseudo-gout is going to have blue. It's going to be a blue hue when parallel compared to a yellow hue under parallel light in gout. Okay? So these are the key takeaway points between gout and pseudo-gout.